we're going to get started, and I just want to give a little bit of a brief introduction on the webinar, how to use the WebEx platform, and then I'll dig into what topics we are covering today and the awesome speakers that we have presenting on those topics. So first of all, everyone from our attendees, thank you again for joining. You are automatically muted. This is just to ensure that we have clear audio for our speakers as they present. And then at the end, we will be having a discussion-based question and answer session. And during that time, we will be unmuting you all and then directing you on how to use your mic. And then that allows for our attendees to actually ask questions to our different panelists and engage in discussion around the topics that we've presented on today. So in the meantime, while you are muted, there are opportunities for you to engage with fellow attendees and panelists. That's through using the chat function, and that is on the right-hand side of your WebEx window. If you use the chat function, you can just send messages to a variety of different people, ask questions if you want, or message myself if you have any technical issues throughout the webinar presentation, and then I'll be happy to help you. In addition to that, there's also the Q&A panel. This is where you can specifically submit a question, and those questions can then be answered by our panelists. So if you have a question throughout either of the presentations, you can submit it there, and we can either go back to it during the Q&A session, or it may be answered as the presentations continue on. And then I'll move into what our topics are for today and our speakers for today. So we'll be talking about palliative care and specifically how to manage palliative care for COVID-19 patients. Our speaker is Dr. Rene Krause, who is an expert in the field of palliative care. She's a family physician with a master's in palliative care and a postgrad diploma in health professional education. She's also a senior lecturer in the Department of Family Medicine and Public Health at the University of Cape Town, and she does a lot of work supervising those who are taking the palliative care masters and supporting them in their work. In addition to that, she also holds a clinical consultant role on palliative care management at Hoogterspoor Hospital in Cape Town. And she's also a board member on the African Palliative Care Association and a member of PALPRAC, the South African Palliative Care Society. So she'll be presenting on a variety of elements of palliative care and then digging deeply into what it looks like in the COVID-19 climate and environment. And then in terms of our agenda, we will first be doing the presentation on palliative care, and then moving from the palliative care presentation to Dr. Alenya's presentation on Uganda's pandemic response. And then we'll be holding a joint Q&A discussion at the end where our members are able to ask questions and get answers from our speakers. So without further ado, I'll let Dr. Rene Krause take over and talk to us about palliative care and COVID-19.
Thank you very much, Rory. And I want to say thank you very much to all emergency medicine personnel, and especially people like Professor Lee Wallace and Katja Evans, who've really been at the forefront of integrating palliative care into all emergency medicine. Thank you very much for that. So Rory asked me to start off, and I know many of you already know this, but what actually is palliative care? Palliative care is a way of doing things. It's a way of looking at how we improve quality of life. And it's not only for patients, it's for families as well. And especially during this COVID pandemic, looking after the families are such an essential component of care. Palliative care aims to not only relieve suffering, but also prevent suffering. And we'll talk a little bit later on how we can prevent suffering during the COVID pandemic at the moment. Also, palliative care is not just a physical, looking at the physical aspects of patient care, but it looks at the psychosocial and the spiritual aspects of patients when we are looking after them. Some of the important principles of palliative care, it looks at a dignified and compassionate care of patients and their families. It is not solely end-of-life care, but it does include end-of-life care. It provides relief of symptoms, and especially in the COVID-19 pandemic, we're looking at symptoms like dyspnea, some pain, anxiety, and delirium, regardless of COVID status or final outcome. It also intends neither to hasten or postpone death and must be provided alongside curative and standard care. Palliative care is definitely not an excuse for no care or poor care. And in all the places where we have integrated palliative care during the COVID pandemic, we've done it alongside the physicians who are looking at providing oxygen, steroids, etc. to these patients. But very important, it must include the family. Palliative care can also be provided anywhere, from the ICU wards, the general wards, intermediate care facilities, or at home. And it is best provided within an interdisciplinary care, team. Clinicians, nurses, social workers, and spiritual carers, and rehabilitation workers are essential components of the palliative care response. By working within a team, we ensure high quality care, and we also are reducing the burden on healthcare workers. Our palliative care team is a small team, and during this COVID pandemic, we've working alongside psychiatry and psychology to provide the best possible care for patients and their families. It's also very important to know that by integrating palliative care, we are not giving up on patients. It has been shown that patients who do receive integrated palliative care actually live longer and have less anxiety and depression and better quality of life. Palliative care should be started at diagnosis, the diagnosis of a life-threatening illness. And as the disease progresses and the patients are not responding to curative care, the palliative care becomes more important. And then it also does include the end of life care of patients. Palliative care also doesn't stop at death, but it continues with bereavement care. And in Africa, the bereavement care definitely also includes looking after vulnerable children and other family members. What is a life-threatening illness? And if I say it should be initiated when a life-threatening illness is diagnosed, it becomes very clinically difficult sometimes to say what a life-threatening illness is. There are many tools, and it should be contextual, and it should be agreed on within your healthcare teams. But this is an example of what a palliative care indicator tool looks like, which really shows that there are disease-specific indicators for palliative care, but also general indicators when we can see patients are not doing well. This is the SPIC tool that was developed by the University of Edinburgh, and it is a very useful tool to use to identify palliative care patients. This is another slide to show how palliative care is integrated in disease management care and end-of-life care and hospice care. And it's with this integrated response that patients actually receive the best possible care. Also, palliative care is a cost-effective method of care, and there are many studies to show that this is not going to break the piggy bank, and that palliative care provides value to the response we are providing for patients. So what is happening with palliative care, and especially in Africa, can we provide palliative care to our patients? We are very fortunate to have strong palliative care advocates in Africa, and I'm referring to APCA, PALPRAC, many palliative care associations across Africa that are really working hard to integrate palliative care. In May 2014, a resolution 67.19 stated by the World Health Organization that palliative care is a fundamental element of healthcare. And this was supported by many African ministries signing the Kampala Declaration in 2016. In South Africa, we have a national policy And here in the Western Cape, we have a provincial policy and framework looking at integrating palliative care. Palliative care is also part of universal health coverage, ensuring that all patients not only have access to preventative and promotive treatment, but also to a palliative care, and should be expose patients not to financial hardships. And this is especially where where palliative care comes in, to support patients not financially, but helping them live through these difficult times. To integrate palliative care, we need many aspects. We need policy, we need medication, we need leaders in the field, and healthcare workers need to be educated on how to provide palliative care. In Africa, palliative care has been integrated mainly on the east side of Africa, and you can see from this slide that how many standalone palliative care programs and policies are. What's also important that when we look at palliative care, it's an integrated response, and it should be integrated into cancer plans and HIV national programs. However, the one problem we are having at the moment of palliative care is that not all the policies are funded. So although we have palliative care on paper, it is mainly done by non-governmental organizations and is not properly funded in the public health sector of many countries. But APCA has done a lot to advocate for palliative care. They have provided us with an essential palliative care package to ensure that African countries have universal access to palliative care. And this was launched last year in Rwanda to ensure that African countries have no excuse not to integrate palliative care. If you see the list of essential medication that are needed to integrate palliative care, you will see that most of these aspects of drugs are already easily available within your healthcare settings. What's very important is that we must ensure that there is access for patients to essential medications and analgesias like morphine. So along came COVID. And what's very important is that the World Health Organization again stated clearly that palliative care is part, an essential component of the clinical response to the COVID-19 pandemic in the form of advanced care planning, and it should be available in all institutions that are looking after patients who have COVID-19. So how do we actually integrate palliative care within the COVID-19 response? Firstly, we know that many patients, actually most patients, will have mild to moderate symptoms, and all they will actually need is symptom control. However, when patients are seen to be critical, and especially where we do not have access or where patients will not go to ICUs, it is essential that palliative care be integrated immediately within the COVID response. And as stated before, this is not just for the patient, but for the family as well. So what have we done here in Cape Town to make sure that palliative care is integrated in our COVID-19 response? If you've been watching the news, you will know that Cape Town is one of the epicenters of the COVID pandemic. The Palliative Care Practitioners Association of South Africa developed a clinical document that provides clinical guidance on how to integrate palliative care. This document has been strengthened by our Department of Health, who provided an operational guide to implement palliative care during the COVID-19 pandemic. And these two documents are cross-referenced in order to make sure the clinicians and the integrators or the people who are implementing care are working alongside each other. So these PALPRAC guidelines, what are they looking at? They are looking on how to manage distressing symptoms, how to have difficult and complex conversations, how to make decisions and support families in making decisions, managing the psychosocial and the existential distress that we are seeing, and looking at lastly on how we actually look after healthcare workers who are dealing with death and dying on a daily basis. Palliative has developed a simple guide that can be put up all across hospitals to provide simple step-by-step guidelines on what medication can be given to patients when they are in distress. And you can see this medication are available in most hospitals. Mist morphine, haloperidol, and benzos are usually quite easily available in hospitals. As stated before, palliative care should be provided across the continuum of care for patients. What we have also done is to ensure that palliative care is integrated in the field hospitals like our CTICC, so that there are palliative care, patients can receive palliative care everywhere, and integrating this within our home-based care response as well, so that patients can receive the palliative care at home. So I want to reflect a little bit on our experience here at an academic hospital on how we've integrated palliative care. Firstly and mostly, we are doing this within a team. And I'm showing you our core palliative care team, but we have extended to include family medicine, to work with psychiatry and psychology and social work. And we always work very closely with oncology to provide an integrated response to care of patients. We have a standardized assessment and referral process. We have a database, and because of the pandemic, we are moving towards a paperless approach where we are including an electronic referral process as well. So there are two main groups that we are looking at in the hospital at the moment. It's the routine palliative care for patients who are known to be palliative care patients and who are known to be COVID negative. It must be understood that these patients' care has changed now that with the COVID pandemic. Firstly, we have to educate our families who are not able to come into hospitals telephonically, and we also have to educate our families on how to keep these patients who are very vulnerable safe. We've got to ensure our patients go home with enough medication, not only to relieve suffering, but to think ahead on how we can prevent suffering. There's been a disruption of the routine referral processes for these patients. Many hospices and intermediate care facilities are very cautious on accepting these patients and do require swabbing before they can go to these facilities. Our home-based organizations are under huge pressure looking after patients and will only go in under real conditions because they have to go in with full PPE. Patients and their families do not have access to the extended families, so there's a lot of isolation and social isolation that is happening to patients with lockdown, and that they are so scared to expose their vulnerable loved one towards other people who might have COVID. One of the other aspects that we have to look at is providing a care plan for these patients and looking at what's the difference between a care plan and an advanced care plan. A care plan is what we do every day when we see patients to talk about medication. But when we are looking at an advanced care plan, is we're looking and discussing with patients their wishes and their preferences. The discussion of an advanced care plan should easily be done before a life-threatening event. It helps the patient express their values and their wishes, and especially helps the patient explain to you as a healthcare person, but also to their families, what their wishes and their preferences are. It takes a huge amount of burden off the healthcare worker when the crunch comes to make decisions. What topics are usually discussed? Who would you like to speak to? Understanding of the illness, current symptoms, fears, expectations, looking at how we're going to address these symptoms, what are the patients hoping for, how do they plan to go forward, what are their support systems, and making sure whatever treatment we're doing today or in the future aligns with that patient's decisions and wishes. PALPRAC has created a checklist or a conversation tool that can assist you to align the type of conversation you must have with an advanced care plan discussion, asking very specific questions about COVID. We must remember patients who do come to hospitals are isolated because their families are finding it very difficult and will not come and visit their loved ones if they do get admitted to hospitals. So this is a very useful tool to have these advanced care discussions with patients during the COVID pandemic. The patients who do have COVID, who gets referred to palliative care? It's firstly the known palliative care patients who are now becoming COVID-19 positive. Also, patients who are high risks and who do not qualify for ICU are referred to us. The main things we are doing, and I must say most of the healthcare professionals are doing it without us already, but we have done ward-to-ward, face-to-face training regarding this, is looking at dyspnea, delirium, and anxiety. But our psychosocial support for the patients and the families have become ever more important. Exploring with patients their wishes and fears, contacting families so that they can understand the diagnosis and the concerns around the prognosis. The family's own health and emotional well-being. General information around contacts. When you are unable to visit your family, you need to know who to talk to and which ward to talk to when your family does go in. Especially looking at their fears and concerns and hopes for themselves and the patient. And finally, to provide spiritual support. Some of our patients are going home, and this is after 14 days. And we've even known of a patient last week who was discharged. She was 104 years old, and the family insisted to take her home. You need to talk about preventing the spread of COVID-19, infection control, talking about symptom management so that the family knows how to treat any symptoms the patient might have, and what to do if the patient does deteriorate, and what do they wish to do if the patient does deteriorate. If the family decide that they will not bring the patient back in if they do deteriorate and want to provide end of life at home, we need to normalize the signs of dying and prepare the family for death. Very important to educate them about elementary nursing education, turning, nappy changes, all the simple things that we take for granted, but families might not know. Where to get psychosocial support and spiritual support. And very important that we are seeing is that many families and patients are stigmatized because of the COVID-19 pandemic. As I said in the beginning, one of the things that palliative care is doing is preventing complications. And one of the big things that we might and help assist preventing is complicated bereavement. One of my colleagues said the biggest impact that this pandemic is going to have on society is complicated bereavement. Patients are dying unexpectedly and alone. Viewing the deceased body is complicated. Funerals are limited, and families don't have closure on what happened to the patient. There is abnormal grieving. There are families dying. And we cannot underestimate the effect it has when the young person knows that they might have been the person to give the virus to their mother and father. This is really complicated aspects, and that's why we are working with psychology and psychiatry to make sure we are addressing these really complicated issues that family members are dealing with. How do we do bereavement? A week after the death, simply opening on how are you doing? Exploring the understanding and addressing misconceptions. There is a lot of stigma around COVID-19 in our communities. Practical advice, identifying the risk and the very vulnerable populations for further referral, and especially further referral to psychology and even to community organizations that can assist. Very important that we understand that children also are undergoing complicated bereavement and might need to be referred further to manage these aspects of their own bereavement. Thank you very much.
Thank you so much, Dr. Krause. I know that this topic is really challenging and has obviously exploded with COVID-19 and figuring out how to manage palliative care in light of everything else that is going on. So thank you so much for taking the time to share your experience and expertise with us. On that note, we do have a resource that was developed in collaboration with PalPrac and has been endorsed by PalPrac. And that I just linked in the chat. It's a comprehensive palliative care guidance, and we hope that you guys will use both Dr. Krause's presentation and the guidance that I just put in the chat to help direct your own palliative care management in the different settings that you're working in. Thank you again to everyone who attended this webinar, and thank you so much to our speakers, Dr. Ngabirano and Dr. Krause, for providing such important information about palliative care and then about Uganda's pandemic response and how we can use that response to adapt to our own settings and our own contexts. We will be having our webinar every Thursday, so please reach out to your networks and let them know that we have them on Thursdays at 2 p.m. South African Standard Time or Central African Time.